So my job is going to be really easy, actually. There is very little evidence of what I'm speaking about. I made it all up. No, I'm just joking. There is some expert consensus on this. So I assume that everyone has seen hypertension here. It's pretty common. I have really no conflicts of interest today with this presentation. I do order lots of blood tests appropriately, and I don't tell my patients which lab to go to, Gamma Dynacare or CML or Life Labs. They decide on their own, so I don't have that conflict. I'm going to start off with a case, and this is probably quite common, a case that you may see. This was a real case, actually, that I saw a few weeks back. It's a 48-year woman with a confirmed diagnosis of hypertension based on automated office blood pressure monitoring and ABPM. She was on no medications whatsoever, and she was otherwise healthy. Her physical examination relevant to hypertension was completely unremarkable. There was nothing suggesting a secondary cause on physical examination or end organ damage, and there was no family history of hypertension in this woman. Her potassium repeatedly, I had some values from the family doctor, it was 3.3, which was just a little bit below the lower limit of normal. Her creatinine was normal, including her GFR, and her urinalysis, a dip, was completely negative. So just some food for thought. Think about what tests you would order next for this patient. So again, I've already defined my caveat here. Most of the evidence is based on expert opinion. A key important thing to remember today is don't order a test if it ain't going to change management, and I think we all know that, right? It's costly, and we have to choose wisely these days because sometimes what may happen in the future is we might end up paying for tests that our patients go for. And I'll give you a classic example. If someone has renal artery stenosis that you think may have renal artery stenosis, you probably don't need to order these specific tests for most of them because it's not going to change management. So again, this is a table that shows the different levels of evidence, and I put the arrow sign there like the radiologists do to show that most of the evidence is quite low. Not Z, but a lot of it is grade D evidence and some grade C evidence. So why do we order tests? Well, there's always a reason we order tests, hopefully, right? We are thoughtful, and we have a process that we go through with our minds and do the best for our patients and as an educational tool to our referring colleagues. So the first number is to help confirm the diagnosis of hypertension. And this often, we don't need elaborate tests to do this often, except for the ones that Dr. Gelfer mentioned, which may be helpful. We want to look for secondary causes, which are probably about 10%, much more common than we think, and I'll talk about that later on just a bit. Screening for comorbidities, for example, diabetes, dyslipidemia, proteinuria, and so on, and also looking for end organ damage, in particular cardiovascular disease, and also help in monitoring the treatment that we're going to put our patients on. For example, if they're on an ACE inhibitor, we should be following periodically, and that's kind of vague, but at least the potassium and the creatinine and so on. Another important thing is, although I did train in the 2000s, we're almost at 2020, our next guidelines are not too far away, it's 2 years away. Investigations do not replace history and physical, and this is really, really important because I do a lot of inpatient internal medicine also and inpatient endocrinology. It's very easy to check those OHIP forms, but to take a history and physical takes long. But we often find a lot of crapomas, and I'm going to use the term crapomas, but you probably know them better as incidentalomas, and those drive me up the wall, whether it's adrenal or pituitary. So I think we have to be very careful and do a history and physical and order the appropriate tests based on that, because we're going to get a lot of noise that we have to deal with. So to confirm the diagnosis of hypertension, I'm not going to elaborate on this because Dr. Gelfer did a very nice job. Often it's pretty straightforward, but to confirm the diagnosis, more often than not, we should probably be using some form of non-office-based blood pressure monitoring, and we've already discussed the ABPM and the home blood pressure monitoring and 24-hour blood pressure monitoring. So generally speaking, to make the diagnosis of hypertension, unless it's extreme and very, very high, it should be done on an out-of-office basis using oscillometric methods or some kind of automated device. So what do we order when we are looking for comorbidities, where we're looking for fasting glucose or an A1C, and I'll leave that to the discretion of the physician. We've left that quite open in our guidelines, in particular the Diabetes Canada guidelines. We've changed the name, by the way. It's no longer CDA, it's actually Diabetes Canada, DC. I think, are we using that short from DC? I'm not sure if we are, but I'm using DC, not Washington, DC, but just Diabetes Canada. We have to use these tests to make the diagnosis or screen for diabetes in space and time, so you can't make the diagnosis based on one test. You want a combination of some kind of test. I didn't put up random glucose, but that may be reasonable also. I'm just trying to follow guidelines here. But guidelines are guidelines. We still have to use our clinical acumen, or a 75-gram oral glucose tolerance test, which I'm rarely doing these days, except for in some pregnant women, to make the diagnosis of gestational diabetes or overt diabetes. We obviously want to do lipids, and I left out fasting because for most patients we don't need to do fasting lipids. We can probably get away with random lipids unless their triglycerides are very, very high. And in ECG, looking for end organ damage such as left ventricular hypertrophy or previous myocardial infarction. If you look back at the PROCAM study, and I referenced it below, about 10% of patients with hypertension have diabetes, which is probably an underestimate, and about 20% have some form of dyslipidemia, whether it's hyper-LDL or hypertriglyceridemia or hypo-HDLemia. So these things exist together. I always call them the cousins, right? Blood pressure and diabetes, they hang out together. They're not independent and working in silo. We also order tests to look for end organ damage. And a lot of this is repetitive, but I think sometimes a broken record is good to pass the message along, because I know after 2 minutes, I can't remember anything, so I need sort of someone to repeat things so I don't forget. So creatinine obviously is looking for end organ damage, and to look for causes too. A urinalysis in particular to look for a proteinuria, and an ECG I've already spoken about looking for end organ damage. So I think we have to be really careful and not order a shotgun approach to tests. I use based on expert opinion and my personal approach, looking at all the guidelines we have and the grade D consensus, is to have a tertiary, sort of a three-pronged or a two-pronged approach. Order some primary tests so we don't overkill the system and find a lot of false positives and perhaps false negatives. So urinalysis, again, looking for end organ damage and for secondary causes. Certain blood chemistry. So potassium is actually very, very important because it might help you choose the right therapy, number one, and to monitor therapy, and also to think about certain secondary causes, in particular hyperaldosteronism. I really love hyperaldosteronism because it's very close to my heart, and it's actually much more common than we think. I think, who's ever seen a case of hyperaldosteronism here? Okay, I think you're all wrong. I think everyone has lots of cases. Okay, I'm saying that with all due respect, but I think we're missing this diagnosis. It's much more common than we think. And again, I can talk about hyperaldosteronism for 1 or 2 days, but for today's purpose, I'm going to talk about it for a very short time. Sodium is important, not for diagnosis often, but more for monitoring therapy, in particular if you're on a thiazide or a thiazide-like diuretic. And creatinine, again, looking for end organ damage and for other secondary causes. We used to have CBC as part of the monitoring, I remember a few years back, but we took it, I think, a couple of years back. I never understood why it was there in the first place. But again, don't order a CBC for this indication. It's not going to really help you. I always think there might have been a reason that someone might have thought of before. And the residents and the students are never wrong. I always tell them they're never wrong. But then I thought, why would someone order a CBC? Then I thought maybe it was sleep apnea and they were looking for polycythemia. And someone said that, and I said, yeah, that makes sense. I'd pass them. Sorry? And smoking, yeah. Or hypoxemia, right? Some other first-line laboratory tests that you may consider or you should consider in someone with a workup of hypertension. Again, we've already talked about an A1C or fasting glucose or a postprandial random glucose, lipids, and an ECG. Again, I've already mentioned that. So that's, again, to look for causes and look for end organ damage. Now, we also need some follow-up investigations also when we place patients on therapy. Lights and creatinine, and ongoing periodic monitoring for their dysglycemia status. Remember, if you look at a CCU, about 1/3 to 50% of your patients in the cardiac care unit have some form of dysglycemia. So hyperglycemia, not frank diabetes, it's in the water, right? It's much more common than we think. So we need to periodically monitor their glucose levels. And in fact, diabetes develops in about up to 3% per year on those with medical therapy for hypertension. So if you're going to live long enough, which you probably are in Canada and the United States because of all the good food we have and all the preventative strategies we have, it's going to be very, very common. And the risk is higher with diuretics, not loop diuretics, but with thiazide and thiazide-like diuretics, beta blockers to a certain extent, and the usual risk factors for diabetes, such as being obese and sedentary and having a predisposed impaired fasting glucose and a poor dietary pattern, and the lipids, obviously. So that's the first tier of tests. That should be probably done in most of our patients. I never say all because 100% is probably an extreme comment, but in most of our patients and depending on their overall clinical status. We also have a secondary panel of tests we should do after thinking through and making sure we review the first panel of tests. So if someone has renal artery stenosis, we probably don't need tests at this stage because we have several studies showing that intervention, whether it's interventional radiology or surgical intervention, does not change outcomes. for most people. There is a select population that will benefit from intervention for renal artery stenosis, depending on the etiology, whether it's fibromuscular dysplasia or atherosclerosis. But if you are going to order a test, in the very small percentage of patients, you can consider a CT or an MRA or a capillary renal scan, as long as there's no drugs interfering. Coarctation of the aorta. Again, we don't see a lot of this in the adult population unless they're transitioned, but in the pediatric population, it may be considered in someone with secondary hypertension thoughts or certain clinical findings. And there, an echo or an MRA or an angiogram, which is conventional, may be helpful. Sleep apnea, again, much more common than we think. We probably all have tons of cases of sleep apnea. Again, there are studies to show recently that treating sleep apnea does not cause significant elevation in blood pressure, nor does treatment decrease blood pressure significantly, but it does improve other things. It may improve your overall quality of life, and there is an association with sleep apnea and sudden death and cardiac arrhythmia, so there's other reasons to look for sleep apnea. Pregnancy is a whole different narrow part of hypertension, and before you start any therapy, making sure they're not pregnant, because certain therapies are indicated and contraindicated in pregnancy. Pheochromocytoma, if someone does not have symptoms of pheochromocytoma and there's no clinical indication or family history, you probably should not be ordering the test. So there is a large registry looking at 24,000 patients with hypertension, looking for pheochromocytoma. If they had no headache, no palpitations, no diaphoresis, the negative predictive value is very, very high to rule out pheochromocytoma. So again, history is so critical here before we order a test for pheochromocytoma, because there are many false positives, such as certain drugs and food interactions, so just be careful. I'm going to talk about hyperaldo just after I talk about Cushing's. Again, if someone does not appear grossly Cushingoid, it's probably not the cause of their hypertension. So again, that's where physical examination actually really important. Cushing's is often a spot diagnosis, just like acromegaly. You'll see the patient in a mall or sitting in front of you in a cafeteria. It's happened to me, I've seen it, and you make the diagnosis. Then you get them to see a doctor and order the right test. Hyperaldosteronism is actually very common. It's probably up to 15% in certain clinics and certain populations, depending on where you're seeing them, but it's much more common than we think. And the problem is people or physicians or clinicians or healthcare providers only think of it if you're hypokalemic. The problem is that about 60% of patients with hyperaldosteronism are normalkalemic or eukalemic, and only about 30% are hypokalemic. So I get these referrals for patients with a potassium of 3.6, which is normal, but they're on an ACE inhibitor, they're on spironolactone, they're on a beta blocker. All these things should actually elevate potassium, but their potassium is still 3.5. That should be a clue that maybe there is something going on that's driven by mineralocorticoid excess. So please think about this condition in someone who's refractory, who has a low normal potassium, who's on multiple medications, who's got a family history, and who has overt hypokalemia. And it's quite easy to order a renin and aldosterone. I'm not going to get into the nuances of how to order these tests, because there is a little bit of a protocol and some understanding. It's got to be done in the morning, upright, it's posture dependent, and got to think of the drugs that they're on to make sure you interpret the ratio and the levels accurately. So this is a table that I'm not going to read out, but I think do they have the slides? I'm not sure. I'd be happy to share my slides, but this is a nice table showing that we have pretty good tests to make the diagnosis, to rule in and rule out these diagnoses, as long as you have a reasonable pretest probability. So there has to be some thought that goes into ordering this test, but we have some pretty good tests for ruling in and ruling out the common causes of secondary hypertension. So back to the case, I'm almost done here. So this is a 48-year-old woman with confirmed diagnosis of hypertension on home blood pressure monitoring. She's not on any medications, and she's otherwise healthy. Her physical examination is completely normal. There's no family history of hypertension whatsoever on a good detailed family history. Her potassium is slightly low, on no medications, and just so you know, she doesn't have any vomiting, she doesn't have any nausea, there is no diarrhea, she's not on a diuretic or any other herbal or over-the-counter medications, and her urinalysis is completely normal. So what other tests would you order at this time? So everyone's choosing extremely wisely, or they're just really tired, right? So would anyone order any tests in this patient? Who would say yes? Just one person? Yes? So you'd order an ECG. Any other tests you would order in this patient? A1C. So we're going to order some tests that we're going to choose wisely. But on this case, do you see anything that's sort of out of the ordinary that you might scratch your head and say this may be not the usual garden variety hypertension? Yeah, the potassium. So what do you think of in someone like this who has a low potassium? Okay. So it'd be maybe referred to a hypertension specialist, which could be a family doctor, could be a specialist, an endocrinologist, a nephrologist, internist. So what diagnosis do you think of in the woman or anyone with a potassium of 3.3 who is drug naive? Hyperaldosteronism. That's all I wanted to hear. Thank you. Okay. I don't get paid by, there is no company that looks after mineral records, so I'm just interested. So I have a couple of questions and I'm done, and we can get a poll here. So the first question is, which test would you not order in someone with recent diagnosis of hypertension as a first-line test? Echo, potassium, electrocardiogram, creatinine, urinalysis. So we'll go from bottom to up, okay? Who would not order a urinalysis? Creatinine, ECG, potassium, echocardiogram. You guys are all really, really smart. You're right. Okay. Echo. So only order an echo if it's clinically indicated, if they have a history of heart failure, you hear a murmur, or you have clinical evidence of LVH. Second question, last question, why do we order tests in hypertension? All of the above are correct, except to look for secondary causes, to look for end organ damage, to help in monitoring therapy, to help boost the laboratory business revenue in Canada. What's the answer? Okay. Bottom line, so there are many reasons to order tests in hypertension, to make a diagnosis, to look for end organ damage, to look for secondary causes for monitoring, and for looking for comorbidities. Order with thoughtfulness, using a tiered approach, and just remember the evidence is mainly grade D for recommendations and expert opinion, and if that's the best we have, that's what we have to work with. Thank you very much.